Right. So the first question is, what might explain her symptoms according to the important clues in the history? So one of you will have to answer this. I won't name anyone, just carry on. So what do you think, what are the reasons for these symptoms? Can you guess? I think you should unmute your mics, few of you at least. Recurrent yellow eyes and fatigue for the past 5 years. Today you all are very silent. Can you hear me?
Yeah, madam.
Okay. So few of you can answer. It's not a big deal, no? So what is the reason for recurrent yellow eyes and fatigue for the past 5 years and has had 2 blood transfusions last year? So what kind of disease are we dealing with? That is what is asked.
A type of hemolytic anemia which cause anemia and at the same time they causing icterus.
Very good. Okay. So she has. So you think it is anemia based on what are the reasons that you are based on your things? Is because of she's fatigue
for 5 years
and
there are 2 blood transfusion because of acute severe anemia.
Very good. Very good. So what makes you say hemolytic?
At the same time, she is icteric,
and
she's due to spleen is palpable.
So you think it is a hemolytic anemia? Okay, very correct. Very correct. She's got a right hypochondrial tenderness and has had several episodes of abdominal colic. Can you relate it to this?
Due to gallstones.
Very good, gallstones, and that would have been the reason for episodes of abdominal colic according to what is given here. Right. Now, this is the classical case, and these are the questions that you get generally for the exam. What other details in history will support the diagnosis? So what else do you want to know now about this girl? I will tell you when you ask. What are the things, very crucial ones that you want to ask?
Any infections and any medication, specific food causing this illness? Precipitating factor?
Okay, something precipitant like infection or drug causing precipitation. Okay, right. What about the etiological questions? Are we happy about this bit, or we want to know more? So you want to know the precipitants. Very good, accepted. Anything else? Somebody else answer, please. What else do you want to know about this person?
Family history.
Does she have a family history? Does she have family history? Very good. Okay. Anything else? Some people don't have family histories, but things could be still familiar. What about if 2 recessive genes join together? There's no family history.
Consanguinity.
Consanguinity. Okay. Anything else? Right. Anyway, I will give you some details about the patient. Now you have told a few things, right? So this is, we need to know the age of symptom onset, isn't it? So then only we can figure out whether it is a congenital hemolytic anemia or acquired hemolytic anemia. So this is one of the major things that we need to consider. So this girl has had age of symptom onset 15 years when she had viral fever, which is, as you said, a common precipitant of hemolysis. She had been unwell for a month, little too prolonged for viral fever, isn't it? So probably she was unwell for a month. She was pale and had mild icterus and was thought to have infectious mononucleosis. Right? Does infectious mononucleosis cause hemolysis?
Yeah, cold
type of autoimmune hemolytic anemias. Okay, so then it was thought to be at that time like that. Children are not much symptomatic. So age of onset symptoms 15 years, what do you mean? It's a congenital or acquired, or could be either? Could be either, right? Even congenital hemolytic anemias, do they have to present at birth? or young age?
Can be present at birth or can be present at young age.
Young age. Can you present hemolytic anemia, say congenital type of hemolytic anemias in the older adults, like, say 30s, late 20s, 40s even? Not 40s, maybe 20s and 30s? Are there some hemolytic anemias which are still congenital appearing later?
G6PD deficiency.
G6PD deficiency, okay, with accepted. It may be after an insult, okay, accepted. Anything else which can appear later? Do you know now the commonest hemolytic anemias that we know are thalassemias? Can they appear later? The audience is very silent.
Trait, thalassemia trait will not be symptomatic at the beginning, and it may be diagnosed later during a pregnancy or something.
Okay, very good. Thalassemia trait is not like a hemolytic anemia, but just like a mild anemia. Okay, accepted. So sometimes, what about thalassemia intermediate groups? Not now only the beta thalassemia majors come very early, but there are so many categories of thalassemia which I have taught you. Those are intermediate groups, very mixed ones, isn't it? Mixed beta and another gene, sickle cell gene and other gene. So those are thalassemia. So intermediates can present even late, right? So that you have to remember. So let's look at the details further. Now it could be congenital or acquired both. So we are thinking about both here. She had been unusually tired during sports meet. It doesn't add too much. No ulcers or painful fingers, right? Do some hemolytic anemias have ulcers and painful fingers? What does this suggest?
Sickle cell and
Sickle cell causing ulcers are caused by small vessel occlusion, and sometimes small vessel digital infarcts can occur, causing painful fingers. Isn't it? So those are features of sickle cell. So low hemoglobin last year was thought to be due to a heavy menstrual period, and she also needed transfusion at that time. So those are the details given. The parents were non-consanguineous. No other siblings had similar illness. Father had recurrent abdominal pain during childhood, recovered after surgery. No records, but has a scar across the abdomen. Now think about this. Father had recurrent abdominal pain during childhood, recovered after surgery. No records, but has a scar across abdomen. She has recovered. What could this be? If the father and the daughter has the same illness, it looks like a same illness, what is the inheritance? Father and the daughter has the same illness. It's not X-linked.
autosomal
Autosomal dominant inheritance. Isn't it? Autosomal dominant inheritance. Father has had recurrent abdominal pain, could be same gallstones, isn't it? He also would have had a hemolytic anemia, recovered after surgery. What does it mean?
Hereditary spherocytosis.
Yeah. Why? What makes you say so? So this scar after recurrent abdominal pain would have been a cholecystectomy scar, but across the abdomen. So probably another procedure was done at the same time, such as a splenectomy, isn't it? So according to the history given, it is most likely that the father has the same illness and has had surgery, right? Probably he got his spleen removed, and then this is an autosomal dominant inheritance of a hemolytic anemia, right? So someone already said it could be hereditary spherocytosis, right? Do others agree with this? Hello?
Yeah, madam.
Okay, anyway, let's look at the few important components of the history, right? These are the few. I have only listed 5 things that you really need in a history of a hemolytic anemia. So most important thing is that you have to make sure that it is hemolysis, not hepatic illness, right? So most importantly, if there's anemia and jaundice, and if there's a splenomegaly, then it is definitely a most likely cause is a hemolytic anemia and jaundice. So you have to exclude other hepatobiliary disease because that might cause confusion. So first of all, confirm from the history that this is really hemolytic anemia, and which is anemia, the patient will have anemia symptoms, or the patient would have received blood transfusions and there would have been a lot of clues to this anemia. Then, of course, you have to know if it is a hemolysis going on, whether it is an intravascular or extravascular. How would you know whether it's an intravascular hemolysis? Does it differ from the extravascular? From patient's symptoms? What symptom will they have if there's intravascular hemolysis? Dark colored urine due to hemoglobinuria. Exactly, dark color urine due to hemoglobinuria, right? You know any disease which can cause the same young female has dark urine on waking up, right? And has dark urine, and it improves color when the day progresses. Do you know any type of such a hemolytic anemia?
Paroxysmal nocturnal hemoglobin.
Exactly. So you know a lot. So that is why you need to first of all ask few questions to make sure whether it's the intravascular hemolysis or extravascular hemolysis. So that is one point. Then onset, progression, and severity of illness you need to know. When did it start? How bad it is? Because you need to treat the patient. Sometimes patient may be so bad and might need recurrent blood transfusions every month or so, and probably have various other complications. So that is one. Then family history, drugs and infections, as you said, and possible complications. Those are the 5 components most important in a patient hemolytic history, right? Very, very important. Suspected of hemolysis. So those are the important things. Right. Now I am going to give the blood count of this patient. Carefully look at it and please interpret it. Hemoglobin 9, it confirms anemia. MCV 90, can you say something about it? What is the normal MCV?
80 to 100.
80 to 100.
Okay, 76 to 96. Okay, 80 to 100. Very good. MCH is okay. Red cell count, white cell count, and platelet counts are okay. So blood count doesn't show anything much. So now how do you confirm hemolysis? So give 4 tests to confirm your initial suspicion. Your initial suspicion was a hemolytic anemia, right? Not a hepatic illness, right? So what are the investigations that you do to confirm hemolysis? Go ahead, otherwise we have to discuss some more questions. So what are the investigations to confirm there's hemolysis going
Blood
on?
picture.
Blood picture. Okay, blood picture.
Blood picture.
Okay, blood picture. Before blood picture, there are so many basic investigations that we can do to show that it's hemolysis. Serum bilirubin, direct and indirect, where the indirect fraction will be high, direct fraction will be normal. Okay, agreed. Anything else? That's the first investigation. Second investigation?
Reticular count.
Reticulocyte count. Second investigation. Third investigation?
Serum
Haptoglobin
LDH.
level.
Sorry?
LDH.
Serum
Haptoglobin
LDH.
level.
Serum LDH, haptoglobin level could be low, ahaptoglobinemia, yes, and blood film. So those are the tests to confirm hemolysis, isn't it? You need retic count, LDH, urine bilirubin, direct and indirect, urine and serum bilirubin, right? And maybe blood picture to add on. What is the next investigation? Now, okay, I'll give you the blood film. What can you see here? Can you describe who is this guy sitting in the middle of the blood film? That is a small lymphocyte. Isn't it? Small lymphocyte is the size of a red cell. So, are these normal looking cells or different? It is normal. They're like bubbles. Some, right? Small. So, generally red cell will have something like a central palo and a outside pigmented circle. Now here everything is like a small ball. So what are these cells? Spherocytes, and it is smaller than this. So this is microspherocytes. Microspherocytes. This cell, what do you think about this cell? This one is a bit large and the color is different. What is that? Even this one, maybe this one also. So what are these? They are actually polychromatic red cells, right? Which shows that there's hemolysis is going on. There's some hemoglobin, some DNA material still there, right? That is why polychromatic, right? Therefore, so this is microspherocytes, suggestive of hereditary spherocytosis. Otherwise, few spherocytes you can anyway get in if there's a hemolytic crisis going on and you have done exactly at the time when there's hemolysis, acute hemolysis going on, you will see so many immature cells coming into the circulation, and those spherocytes are generally larger than normal, right? So they are macro. This is a microspherocytes, right, in hereditary spherocytosis. Right. So what is the diagnostic test to confirm the hereditary spherocytosis?
Osmotic fragility test.
Right. Okay. Now we have this patient with recurrent abdominal pain and jaundice and anemia, and you have now confirmed hereditary spherocytosis. Are there any further investigations that are relevant to do in this particular patient?
Ultrasound scan abdomen
To
exclude gallstones.
Exclude gallstones, very important, because the patient should have a polycystectomy if there are gallstones, isn't it? So now, so that is the investigation, other additional investigation. How do you rule out immune hemolysis? How can we definitely say that this is hereditary spherocytosis? Sometimes with any hemolysis you can see spherocytes. And how can you say that this is not immune mediated hemolysis? Now, you know, hemolysis could be so many factors. No, hemolytic anemia could be congenital and acquired. And under acquired component, there are immune mediated and non-immune mediated and mechanical. So practically there are 4 types of hemolytic anemias. Congenital, under acquired, you have immune, non-immune, mechanical. So immune ones are the ones, they are also late onset. Younger people may be, middle-aged people may be, old-age people may be, right? But what is the classical test that you do to rule out immune-mediated hemolysis?
Holmes test.
Direct home test.
Direct home test. So sometimes you need to do a direct home test and exclude immune hemolysis as well, right? Unless you have confirmed it by those classical family histories there, microspherocytes in the blood film are there, and osmotic fragility test, if all of them are positive, then you don't have to do a Coombs test. But if their family history is negative, always it is advisable to check out for immune-mediated hemolysis. Now, let's go through some further questions. What treatment in general would you give now? If somebody has a hemolytic anemia of this nature and has episodes of hemolysis going on, what general treatment, what are they generally deficient of? Iron deficient?
Folic acid.
Yeah. Yes, dear?
Folic acid supplementation.
Generally, you need to give folic acid supplements for this patient. Now, what would you plan now further? Do you think that we need to, how do you recognize developing folate deficiency? How do you know whether the patient is getting folate deficiency and that is the cause of the anemia, worsening anemia? Folate deficiency. If there's folate deficiency going on, then factory can't produce cells. So therefore, reticulocyte count will drop and anemia will be progressive. Isn't it? If there's real deficiency, then other blood changes of folate deficiency will come, right? So, but if the reticulocyte count drops, that means the patient is probably has some deficiency. He has no some substance is going low, right? So that is important to know. So what information will be needed to give for this patient? What would you tell him? What would you tell her? No, she's asking what have I? Yeah?
To prevent precipitating factors.
Yeah. Are you going to tell about the illness first?
Yeah.
What would you tell her?
This is an inheritance illness, which is autosomal dominant, and it is not a fatal illness. Time to time, it can cause anemia and icterus like this. Maybe precipitating events to cause the illness worse. So you have to prevent those precipitating factors, and as a management we can do splenectomy, and before that if the gallstones are present we have to do cystectomy first.
Very good. Okay, excellent, well done. What are the common reasons for anemia in this age group? What is the common precipitant? Maybe unrelated to your hemolysis, some other mechanism.
Generation.
Yes, iron deficiency, menorrhagia. So patients come as a whole, right? Not as diseases. So we need to think about all these things. Dietary and other deficiencies also need to be corrected. So that information you have to give. So it is not a fatal illness. Is a very good point, right? And she probably got it from father, isn't it? And probably she need to be monitored and followed up. And we might have to take a further step if the anemia is getting worse, isn't it? What is the further step that you are going to get if it is getting further worse? What step? Splenectomy. Okay. Those things are generally reserved for people who have severe hemolysis going on, right? And also if the spleen is very becoming troublesome. Otherwise, for a mild hemolysis, you are not going to suggest that. For that, of course, there are things to follow. So you can see here the patient's blood. So this is a osmotic fragility test in a graphic way, right? You can see by the time that the concentration is lowered to below 0.5, right? So this is 0.9 is normal saline, no hemolysis, right? No one will hemolyze when they have saline, right? So when it is lowered and lowered, you can see that they have started hemolysis just after 0.5% normal saline, and by 0.4 saline, the hemolysis is completed, right? A normal person is starting, but a little later, right? Completing hemolysis takes further later. They have already completed by 0.4%. So that is, these graphs might be given for your interpretation, right? So what preparation is needed for a splenectomy? What preparation is needed for a splenectomy?
There's risk of infections due to capsulated organisms. So we have to vaccinate the patient prior to the splenectomy, 2 weeks prior, with the pneumococcal vaccine the hip vaccine and the influenza. And meningococcal.
Mainly pneumococcal and Haemophilus vaccine. And after that, are you going to give some drug also?
Prophylactic antibiotics should be given for penicillin.
Penicillin, yes, to prevent again capsulated organism infections, which can be life-threatening. Will you see some change in the blood film now?
Reduce, increase.
Okay, very important observation. Exactly, yeah. Increase in platelet count, that's fine. It might increase a bit, but it will not carry on throughout. It's not ITP now, so platelet count will stabilize. But any other things that you can see after hemolysis? Splenectomy?
Spherocytes will be there in the blood film,
Okay.
but hemoglobin will be increased.
Very good.
In full blood count.
Very good. Any other body which will come after splenectomy?
Heinz body.
These bodies, no? These are Howell-Jolly bodies in splenectomy, where this is the nuclear remnant, right? Nuclear remnant parts are there. And in a normal person, it will be eaten by the spleen. Now there's no spleen. They will remain spherocytic, but they will never be symptomatic after, because spleen is not going to eat them. And the Howell-Jolly bodies can be noticed after splenectomy field. Right? These are common questions that you come across, right? So remember that blood film will be spherocytic. There won't be any hemolysis. Howell-Jolly bodies will be there in the film, right? Right. So this is what, any complications? Sorry, any complications of this other than gallstones? Any other complication of chronic hemolytic anemias? You can talk in general.
It is a small child, there will be
growth failure, pubertal failure. Exactly. If it is thalassemia, the facial and everything will change, appearances will change, isn't it? And then if there are transfusion dependent anemias, what are the complications?
Iron overload.
Iron overloading everywhere, isn't it? Liver, heart, right? Pituitary. So therefore hypogonadism, pancreatitis, chronic pancreatic failure, cirrhosis, isn't it? All the complications will come when there's iron overloading, right? Sometimes certain complications will come straight away. Really hemoglobin will be low. Some crisis happens. What are those crises? Those crises can happen. After infection, suddenly the hemoglobin dropped like low. What could have been the crisis?
Aplastic anemia.
Aplastic crisis. There could be hemolytic crisis, aplastic crisis. Of course, sickle cell anemias will have various crises like sickling crisis, sequestration, lot of things. So we are not going to talk about all. At least you should know few complications. Don't forget the aplastic crisis, right? Which can be following infection and also which could be due to folate deficiency. Both can cause aplastic crisis, right? And suddenly hemolytic crisis due to some insult, right? So those two things remember. Right, I think we have so many questions today. So we will go fast for the rest of the ones, right? I want you to answer these questions. They are not so difficult, right? So now we are going to get case 2.
Can I ask a question?
Sure. You can ask questions. Okay, you
Do
go
we
ahead.
start prophylactic antibiotics before the procedure or just after the procedure?
Which antibiotic? Which procedure? I think you can perioperative, I would suggest. Perioperative, right? You should not be waiting too long, right? So anyway, perioperative, the patient will be on antibiotics now. That period, as soon as those antibiotics stops, I would suggest to start. It's a prophylactic, right? Any other questions? Are very silent. I don't know why. Right. Anyway, let's look at the second case. We are going fast now. A 70-year-old man, fairly elderly man, has anemia and he's on long-term treatment for hypertension. His blood pressure is 190 by 100, right? And he has leg swellings on arrival. And the blood count shows only anemia. Little low towards MCV is a little low side. So looking at this picture, what is the most likely cause of his anemia?
Renal failure.
Exactly. Acute renal failure or chronic renal failure?
Chronic renal.
Chronic renal
Most
failure.
likely. So give a complete answer. Anemia due to chronic kidney disease or chronic renal failure, isn't it? Right? So that is the most likely cause. Why do you say so? Why do you say so?
Elderly man presented with
No.
hypertension, having low hemoglobin.
Hypertension and anemia together, always think of CRA. Hypertension, anemia together is always CRA. Right? And there's another
Bilateral
clue, bilateral
hemoglobin.
leg swelling. So how do you confirm the diagnosis here? So I have given creatinine and EGFR. Creatinine 2 milligram per deciliter, that's double, and EGFR of 45 milliliters per minute. So what can you say now? What can you say?
Stage 3
Okay.
renal failure.
Stage 3 CKD, fine. Stage 3 CKD. What could be the cause? In old people, what are the common causes?
Hypertension.
Hypertension is the cause. Glomerulosclerosis, okay. Good.
And there may be comorbid diabetes mellitus.
Comorbid diabetes mellitus could be causing diabetic nephropathy. Agreed. Anything else? Old people, I said. Old man, I said. So use your clues for your first differential diagnosis. Use the clue for the first differential diagnosis. This is what you need, why you need to do clinical correlation, right? You have to do a little bit of thinking. Yes?
Urinary outflow obstruction.
Exactly. Male patients, exactly, you have to think about outflow obstruction. Outflow obstruction from where?
Prostatomegaly.
Obstruction, right. Ultrasound scan, bilateral obstructive uropathy and altered corticomedullary demarcation suggestive of CKD. No calculi were seen. So most likely this could be due to lower obstruction and due to. So what investigation would you do now for this patient? What investigation would you do now? Is the prostate just the prostate, or what kind of prostate can we know? Can we know it from a blood test?
PSA.
PSA, isn't it? PSA, because you need to exclude maybe prostate ultrasound scan, isn't it? Rectal examination, all those things are included, and PSA is important, right, for this patient to complete the rest of the investigations, right? Urine examination is important, isn't it? There may be coexistent obstruction and urinary tract infection, right? So urinary abnormalities and albuminuria as a cause of glomerulopathy is less likely in this patient, right? If a younger person comes with renal failure, you have to think about other causes also, isn't it? Glomerular, vascular, tubular, right? Interstitial, all those causes are possible for a renal failure, right? So in this particular patient, there had been obstructive uropathy, so PSA is important. So what are the mechanisms of CKD in causing anemia? What are the mechanisms? What do you think is wrong in CKD? What is the major mechanism? Why should it cause anemia?
Erythropoietin
Deficiency of
Yes.
erythropoietin.
Very good. Relative deficiency of erythropoietin. Some people erythropoietin is normal, but if somebody is anemic, erythropoietin goes up 10 to 100 times. But in relatively, erythropoietin is deficient, right? It doesn't increase in CKD. So that is a possibility. Very good. Anything else? Is that the only reason?
Poor nutrition.
Poor nutrition causing what?
Hyperuricemia.
Poor nutrition causing which deficiency? Coexisting, very common, and sometimes mistaken. Mistaken as CKD, causing anemia, but deficiency somewhere else.
Iron, folate.
Yes. Yes. More than B12 and folate. That is also possible, B12 and folate, because they can be lost actually in dialysis procedures. If the patient is on dialysis, B12 and folate can be lost, especially if you are doing a peritoneal dialysis, those can be lost. So iron deficiency is very important because of reduced appetite. And any other reason why iron should be deficient in a patient, even if say other than appetite, any other reason for iron deficiency?
Uremia
Yes,
causing
iron.
reduced lifespan.
Yes.
Uremia causing reduced iron lifespan of red blood cells.
Okay, uremia can cause, so that is another mechanism. Uremia causing reduced lifespan of red cells. Okay, that is accepted. But iron deficiency can result from iron deficiency can, yes,
Blood
Edema
loss
and
from
absorption impairment.
gut edema and absorption impairment. Good thought, yeah, right? But importantly, lot of venisections, isn't it? Venisections and blood loss sometimes. Anemia people have, CKD people have various forms of blood loss because there's coagulation also defective. So small amounts of blood can be lost chronically. And dialysis also sometimes, dialysis catheters, so many procedures. During dialysis also there could be little hemolysis going on. So, and venisections are very common, right? So iron could be deficient. So iron deficiency is very important. Erythropoietin and CKD is very important. Somebody said uremia can cause various other reactions and cause sort of anemia, right? So those are mechanisms, and also hemolysis can be associated with dialysis, right? So those are the important causes of anemia, mechanisms of anemia. So how do you confirm the presence of iron deficiency? How do you know whether the patient has iron deficiency also? In a patient who has CKD and iron deficient. How do you diagnose that?
iron studies, serum ferritin and trans.
Serum ferritin, can it be high in a patient with CKD?
Yeah, can be acute.
So then which test would you choose?
Transferrin
Transferrin
saturation.
saturation.
Exactly. Transferrin saturation less than 20 is very important to confirm iron deficiency. Transferrin saturation. So this you have to be using your cautiously using investigation, right? So how do you treat anemia in a patient with CKD? Now that patient, of course, will need a relieving of obstruction and checking whether it's a prostate, CA. Those things are included, but we are now specifically managing this patient's anemia. So if they're CKD and anemia, how do you manage? I'm sure you have seen a lot of patients who have been managed in the wards. What do you give them?
Erythropoietin subcut injections
Yes.
twice weekly, and the with iron supplementation with ferrous sulfate.
Iron supplementation if the ferritin is low, or sorry, if the iron studies show low values, and also erythropoietin, as you said, right? Erythropoietin subcutaneous, short acting ones are there, long acting ones are there. The important thing is when to start and when to stop, right? So generally, you can start if the hemoglobin is below 10. Below 10, that is a general recommended guideline. In our country, it may be even we started slightly even lower, but below 10, it has to be below 10, right? And importantly, it should not exceed, right? It should not exceed 13, right? Because erythropoietin has other effects, other tissue effects, right? Therefore, it can cause hypertension, right? It causes hypertension and various other adverse effects are there, common adverse effects and uncommon adverse. Hypertension is one of the most important things, and high erythropoietin doses are could be associated with high mortality, right? In certain studies that shown. So very cautious, right? So starting point is around 10, and maybe you should not exceed 13, right? So when you start, the hemoglobin will rise, and depending on your response, you will give. How many units like do you give, say, erythropoietin alpha? Have you seen the units amount? It's about 4,000, 8,000, like that you give, right? So twice weekly or weekly, depending on the patient's response. So that is how you treat. So anemia and CKD, if there are losses, you have to correct. If there are losses, you have to correct. If there are deficiencies, you have to correct, right? And if the still patient is having anemia progressive, then the patient has to be given erythropoietin. Can we give blood transfusions? Why can't we correct it with a blood transfusion? Erythropoietin is very expensive.
It depends on the long-term plan of the patient. If the patient is awaiting kidney transplant, it can interfere with it.
Exactly. So if there's a kidney transplant is awaited, then you should avoid. If you want to give, how do you give? If you still want to give blood, how do you give?
Leukoreduced or washed?
Yes, leukodepleted. Washed red cells is different. Washed red cells is different. This you have to give leukodepleted, where you have there are so many other ways of giving blood, like irradiated, leukodepleted, right? Different forms of blood. So you have to use leukodepleted generally if you are going to go for a transplant. So blood also can be given if it is urgent. Anyway, you are going to give, right? You have to save the patient's life. So blood transfusion in this instance, erythropoietin, iron, and checking on the rest of things and correcting the underlying deficiency. So all those things have to be included. How do you treat anemia in this patient with CKD, right? So all has to be included. Right, now this is the prevalence of anemia. You can see when it is stage 5, right, less than 15 ml per minute, GFR more than half has from stage 4, right? That's about less than 30 ml, right? So very common. Right, anyway, we are short of time, so we are going to now go for the third case, right? You can take a breath and read the question now. Right. What is the hematological problem here? What is the hematological problem here?
Pancytopenia.
Pancytopenia, so there's no big deal. What differentials would you consider here in the pancytopenia? What are the differentials? Not many, few. Categorize all of them. Start with one.
Aplastic anemia.
Aplastic anemia, very good. That should be the first. Aplastic anemia should be the first. Second.
Multiple myeloma.
Multiple myeloma is correct. But let's concentrate on the mechanisms first. So aplastic is one mechanism, aplasia.
Megaloblastic anemia.
Megaloblastic anemia. Under that, you have B12 and folate deficiency. Okay. Anything else? Can all people? Yes. Yes.
Splenic sequestration.
Okay. A large spleen and sequestration, right? Okay. If somebody has a large spleen, a man has a large spleen, can you explain another mechanism? something can become fibrotic, no?
Myelofibrosis.
Myelofibrosis. So that is another mechanism. So you have myelofibrosis. Can infiltration, somebody already said, myeloma causing infiltration, isn't it? Infiltration. So those are the mechanisms. So like this, megaloblastic anemia, aplastic anemia, myelofibrosis, and bone marrow infiltration. Those are the 4 causes. It could be peripheral immune destruction also, but this is relatively uncommon, so I have not listed it out. Now, under aplastic anemia, you know there are drugs, infection, chemotherapy, and radiotherapy all can cause, right? Right. So differentials now you have considered. So what kind of further clinical details will be there? Now myelofibrosis, you already said that there could be a big spleen, right? So aplastic anemia, no physical signs other than anemia, thrombocytopenia, causing bruising, but historically there will be drugs, infection, and various other things which are given to you, right? Give one drug which is used in rheumatoid arthritis which causes aplastic anemia.
Methotrexate.
Methotrexate, right. Right. So then another student said bone marrow infiltration like a myeloma, leukemia, lymphoma, carcinoma all can cause bone marrow infiltration and pancytopenia. Leukemia at only one stage, right? Subleukemic kind of stages, but after that the counts will be changed, right? Not pancytopenic, but more white cells, right? So clinical information is needed, like you already know, dietary, whether the patient is a vegan, right? And then certain physical examination and historical details we already discussed. But don't forget, if the patient is an old patient, ask about fever, backache, and system inquiry to find whether there's a malignancy going on, right? Malignancy going on, right? Any pancytopenic patient needs examination, spleen examination, lymph nodes and masses, bone tenderness, don't forget, and brisk reflexes and optic atrophy, suggestive of what? Brisk reflexes and optic atrophy. Right? B12 deficiency cause megaloblastic anemia and subacute combined degeneration of the cord, right? Which causes brisk reflexes and optic atrophy. Right? B12 causes neurological effects and hematological effects. Both are there, right? Not only one, neurological and hematological. Right. Interpret this blood film quickly. What am I doing? I'm counting. What?
Hypersegmented nucleus or neutrophil.
Very good. Hypersegmented neutrophil showing 1, 2, 3, 4, 5, 6, 7, 8 segments, right? 7, 8 segments, and you can see, we can't see much platelets, right? But you can see there's some macrocytes going on and a lot of anisopoikilocytosis there, maybe some different reason, but you can see that there's a hypersegmented white cell, right, with reduced platelets, right, and some macrocytes, especially oval macrocytes are very important, right? So that is a B12 deficiency. How do you confirm? So this patient has been a total vegan for 20 years for religious reasons. So how do you confirm B12 deficiency?
Serum
So most
B12 levels, but it's more
yes,
expensive.
yes, B12 levels, but do you need a bone marrow here? He is pancytopenic. Just because he's a vegan, I have taught you all the pancytopenic people and all people with macrocytic anemias need bone marrows. Microcytic Hypochromic anemias don't need bone marrows as much, but all the macrocytic anemias and pancytopenias need bone marrow. So so how do you confirm the diagnosis? You need a bone marrow examination and to see megaloblastic changes in the bone marrow, because we are suspecting of B12 deficiency and he had been a vegan. So most likely you need B12 levels and a bone marrow examination, because sometimes you get surprising results. He may be a vegan, but bone marrow would have been infiltrated with malignant cells, right? So it's very important that we do a bone marrow examination. And how do you treat B12 deficiency? How do you treat B12 deficiency? B12 tablets?
Intramuscular vitamin B12 injection.
Intramuscular vitamin B12 injections. Intramuscular vitamin B12 injections, first twice a week, maybe twice or thrice a week, right? With reducing frequency to about once a month. And after that, every 3 months, if it is pernicious anemia, for lifelong, right? For lifelong, every once in 3 months. But initially the frequency is either 2 to 3 times a week. So how you know the response, the hemoglobin will respond and the reticulocyte count will become up and bone marrow megaloblastic changes will become normoblastic in 24 hours time, right? In 24 hours, the megaloblastic changes will become normoblastic. So that is how you treat this elderly person. But don't forget the bone marrow and excluding malignant possibilities, right? So malignancy is very important. Malignant, what are the malignancies which spread to bone?
Thyroid, breast, lung, prostate, and kidney.
Very good, right? So don't forget those. Right. So we are going to our last case. Few questions only left, right? So this man has bilateral large painless progressive inguinal swellings noted for 1 month. He is pale, icteric and sweats profusely at night. Bilateral large painless progressive inguinal swellings for 1 month. Pale, icteric and sweats profusely at night.
Lymphoma.
Very good. Lymphoma. Most likely lymphoma. Anything else similar? Differential diagnosis?
TB lymphadenitis.
Okay. Disseminated TB because he's got jaundice also, no? Jaundice, disseminated TB is a possibility, rare, uncommon, but possible. Anything else? Inguinal region, nodes, icteric, sweating. Yes?
Syphilis.
Syphilis. Syphilis has different manifestations. How to explain icterus? Those
Malaria.
are malaria, inguinal nodes and icteric sweating, but malaria has fever. No, this one has only profuse sweating. Isn't it? That's unlikely, right? But good guesses.
Sarcoidosis.
Sarcoidosis? Yes, you can consider sarcoidosis. Maybe liver infiltration causing icterus, hematological issues causing pallor. Okay, sarcoid, maybe sarcoid, not very common, but possible. So either a lymphoma, as you said, it could be a CLL. Chronic lymphocytic leukemia is also similar, very similar to a lymphoma. Again, rubbery lymph nodes, not only inguinal but elsewhere as well. But night sweats, all those symptoms are there like a lymphoma. It could be an intra-abdominal malignancy, you know. Why not? Jaundice, inguinal lymph nodes. So think about the region, right? This is not exactly a very generalized lymphadenopathy. Now, if you have a generalized lymphadenopathy, you have one differential diagnosis. If you have regional lymphadenopathy, you can consider regional problems also. So if you take the inguinal region as a region, it could be a intra-abdominal malignancy also. That also can be taken as differential diagnosis, but I agree that it is more like either lymphoma or leukemia, right? Right. So so these are the investigations. Just look at the blood count. You can see that the patient is anemic, MCV is 100, white cells and platelets are okay. ESR is very high. So what diagnosis could you exclude here? Out of the 5 differential diagnoses, if the white cell count is normal, I have told you so many times, if the white cell count is normal, what would you exclude?
Tuberculosis.
No, Puta, white cell count can be normal in tuberculosis. Leukemias, isn't it? Leukemias, CLL has about very high white cell count, about 30-40,000 lymphocytes. Right? White cell count is about 30,000, 40,000. So chronic lymphocytic leukemias, you don't have to do a bone marrow. Sometimes when you look at the blood film, you can diagnose. Right? So leukemia, chronic lymphocytic leukemia is just like lymphoma. Lot of lymphocytes in the blood film. Lymphomas are like them, but the lymphocytes are in the lymph nodes, not in the peripheral blood. Remember forever. Right. So you would exclude CLA, right? What further investigations could be carried out? I am sure you know how to investigate a case of lymphoma. What are the most important things to carry out? Give me some most important things to carry out in this patient. Don't only think about hematological investigations. There are other investigations also. Important. If the blood count is like this, ESR is like this, what will lead to a diagnosis? This one has palo, icterus, and inguinal lymphadenopathy, large lymph nodes. Yes?
Exclude intra-abdominal malignancies by ultrasound scan.
Okay. So image.
Lymph node biopsy.
Lymph node biopsy. So ultrasound scan or a CT would be better. Staging CT could be better, right? Because we have to think about the best investigation. Ultrasound and CT both correct, and probably you need a lymph node biopsy, isn't it? Lymph node biopsy, if it is even an abdominal malignancy or whatever, it will be shown in the, if it is disseminated to lymph nodes, you can see. But this is most likely a lymphoma. That is our first differential diagnosis, and investigations are favoring that. So therefore, you need a blood picture to exclude chronic lymphocytic leukemia, and then to diagnose a lymphoma, you need a lymph node biopsy. The patient is anemic, so probably patient will need a bone marrow examination also. So I have asked, give 3 reasons for this patient's icterus. Thinking that this is a lymphoma. Imagine that the patient has a lymphoma. Sorry, that part is missing here. So if the patient has a lymphoma, why is he icteric?
Autoimmune hemolytic anemia.
Autoimmune hemolytic anemia. Exactly, autoimmune hemolytic anemia is a possibility. Very good. Any other reason?
Liver deposits.
Liver
Deposits.
Yes. Liver deposits. Exactly, that's correct. Can they have obstructive jaundice also? Sometimes these lymphomas. Can he have obstructive jaundice? There are lymph nodes all over.
Yeah, because there can be deposits in head of the pancreas also.
Can't you give a better? You are correct. Some are closer to obstruction, causing obstruction.
Porta-hepatis lymph.
Yes, porta-hepatis like lymph node. So, and there could be obstructive jaundice by either a mass, lymph node mass at the porta, but most likely, as the student said, first your colleague said, it's most likely a autoimmune hemolytic anemia, right? Autoimmune hemolytic anemia, right? Right, now I think we have time to conclude, but you can ask questions. If you have any clarifications, you can ask now. Anything else? So other investigations like we did not discuss, like lactate dehydrogenase and so many other things, like for a lymphoma we do liver functions, of course we have to do in this patient because he has jaundice, right? Reticulocyte count has to be done, right? If the reticulocyte count, we don't know whether it is autoimmune hemolysis due to warm or cold or what. So therefore you might have to do a Coombs test. So those things are included. So definitely the patient needs a liver function testing, right? Reticulocyte count, Coombs test, lactate dehydrogenase levels, right? And then most importantly, imaging studies, ultrasound scan followed by a CT scan, right? So what are the options for treating this person if it is turned out to be a lymphoma? What do you do now? What do you do? He has a lymphoma and confirmed by lymph node biopsy, and lymph node biopsy showed a diffuse large B-cell lymphoma, which is the commonest one. And B cells are the ones which produce antibodies, and he also has autoimmune hemolytic anemia. So now you have what are the principles of treating? What are the principles of treating a lymphoma?
Radiation and chemotherapy.
Yes, that's simple, no? First of all, you state the case, isn't it? And you supportive treatment all possible, right? And then, of course, either it is chemo, radiotherapy, or both, right? So there's nothing really difficult about it, right? So either chemotherapy, maybe sometimes surgical treatment if it's very one or two, but those are not common options for this patient. Probably combine chemo, radiotherapy, and staging, isn't it? Whether it's above the diaphragm or below the diaphragm, all these things are covered in lectures, right? So now, I think time is up now. So if you don't have any questions, we will conclude. You can just mail the Google form as well, right? Anything else that you want to talk about here? Any other issues?
Madam, the last question, can't it be HIV infection?
Possible. This lymphadenopathy.
Yes, madam.
Generalized lymphadenopathy, HIV generally causes generalized lymphadenopathy, isn't it? HIV seroconversion syndrome is one cause of just simple small lymph nodes, right? That is one. Then the second type of lymphadenopathy in HIV is PGL, progressive generalized lymphadenopathy. So those are the two things now possible. One is seroconversion inverse can cause like a IMN-like illness and cause fever and lymphadenopathy, which will be transient and which will go away after some time. Other one is PGL, progressive generalized lymphadenopathy. Generally, it is progressive. But even if you say that this is advanced HIV, I think that is probably an acceptable answer, right? But generally causes generalized lymphadenopathy. That is the category that they fall into. Okay, but we don't know how generalized these things are because certain things are intramediastinal and intra-abdominal, and not all the lymph nodes are palpable. Remember that also. Not all the lymph nodes are palpable. Sometimes are mediastinal, some things are intra-abdominal. So sometimes lymphomas do not have palpable lymphadenopathy because the lymphadenopathy is somewhere else, right? Okay, I will accept that answer. Right, so then the class was very silent today, right? I don't know why. Right, so anyway, thank you for attending, and we will meet in another forum like this. Please don't forget to fill the Google form. Thank you very much.
Thank you.
Thank you, madam.
Thank you, madam.